organizers, General Parmar, and in presence of my guide and teacher, General Pavan, I'm speaking, and the august gathering here. Well, the topic is not away from each one of us, and we face it on a daily basis. Our hospitals are complex organizations, as we all are aware of. It's much different because multiple processes, multiple protocols, multiple systems, multiple people on the same patient. Now, can you make a guess as to how many hands does a patient go through during a 5-day admission? A simple admission to a hospital for a 5-day period. Let's have a look. This is how it goes. This is the day 1. The patient is here. It's brought in. Subsequently, he's been checked. And that is the team which is evaluated. Fine. It goes further. Day 2, there is a plan for surgery. Subsequently, more people have looked. And the number goes higher. You can see in front of you. Apart from this, there are many more which have also touched, interacted with this patient. And subsequently on day 3 and day 4, the journey continues. It is a shift to OT, transfer to surgical ICU, various other teams, roughly a figure of 48 odd people and still counting. And subsequently, we see that it happens on the day of the discharge. If I say roughly 3 people have also, that is a billing or other people, we have 51 people from our healthcare workers which have interacted at some point or the other with this patient. Now, the question lies here that this stranger who came to us as a patient is amongst those 51 strangers. How well do they know each other? How well the processes are standardized? How well the interaction is taking place is happening through an interface which is called as human relation, human beings. Now, why our industry is talking about it? Why healthcare? It doesn't happen in any other. Why? An automobile industry is picking up cars and manufacturing an assembly line. An IT industry is working through desktop smart working places. We are the people who are working and delivering through the human beings, continuously, round the corner, 24/7, 365, with life-saving in front of us. Now that is a challenge we face, but where do we stand? Now, that is a question in front, and based on this complex situation, this study was aimed just to carry out the analysis of communication which is taking place at the handovers. The primary objectives were to examine whatever is existing, to review and to find out the root causes at the bottom line where it happens, and to recommend, come up with certain measures where we can improve upon it. Now what happens? The literature is in front of us. It states clearly that deficiencies are identified in handovers. The only thing which comes back is the lack of standardization. The standardization among the communication channels, the care which is being provided, it is far away from that. Hence, an audit is not just an audit where we are finding faults, it's a retrospective analysis where we are trying to bring in how well the caregivers to the patient himself, and so many people with us who are delivering onto one patient are interacting. The methodology is here, and what we did was we made certain checklists. These checklists were brought in the form of wherever the patient interface is happening, and between physician to physician, physician to nurse, nurse to patient, and so many interactions, and an observer-based checklist was followed up. At the same time, questionnaires were given, and it was subjected to the patients, to the healthcare workers, that is through the doctors, the nurses, and so many people. And then came an output which came as the results, which showed very clearly that fine, out of whatever we evaluated, there were around 200 samples studied. Planned cases were 80% and 20% were emergency. So 80% are coming as planned cases which we have thought about them before. Nurse-nurse interaction is around 58% and 42% was around 50 nurse-physician interaction which was taking place. The variation comes up because it is at this point that the doctors are at 8 o'clock or 6 o'clock in the morning, and somewhere in the evening, they are having an interaction with the nurse during ward rounds. And because of the shift changeovers of the nurse, which in our setup has 3 times in a day, that is in the morning, in the evening, and in the end, there is a variation in the patient handoffs which are happening. Now, type of communication, most of it is combined. At the only point which is patient-nurse, which is more of a verbal communication which is taking place. Now, this is important. What happens when the information is provided? If we see that if in red is the physician and the nurse interaction, and the nurse-nurse interaction is in blue, you can see that the points like diagnosis, current status, and current treatment is fairly good, 100% among the nurses. They are giving this, whatever is going on, they are percolating it down to the next person who's taking over from them, between nurse and nurse. And similarly, the alarm points, the previous medication, advanced directives, and special needs. But the issue comes up between the physician-nurse interaction. And that is, we see that alarm points, previous medication, and so much of that which is going around 50 to 60% only. Now, where is this 40%? This is 40% is what will eventually take up, and the patient's, the healthcare provider that is on ground, the nurse is not aware of the alarm points when she's supposed to raise the trigger point. Okay, adding on to this, if we see that interactive, if you on the bottom of it, you see on the red color is again physician-nurse interaction. In the middle is the nurse-nurse interaction, and the top is eventually what is going down to the patient, that is a nurse-patient interaction. This is where we stand. The interaction between the nurse and the doctor is around 53%. Back questioning to the doctor, whatever questions are coming up, is around 39%, and verification and timeliness, how much length of time the doctor has given for this communication to the nurse, is coming to around 53%. And so much is that in the variation which is coming amongst the nurses, which again comes up with the point that how much have they reviewed the historical data, which is around 40%. They're doing what they were told to do. Did they go back and check if something is going wrong? And again, the issues like interruption-free environment where they are providing care, 60% only. 40% of the time, there's multiple chains, multiple actions, sometimes phone calls, sometimes other things are happening. So obviously, the interaction is happening, which is not interruption-free. And in the end, the patient, which is getting it from the nurses, we can see in front of us that the figures are approximately 60 to 80%, which are touching. We are nowhere beyond that, or subsequently, the errors are happening because somewhere the patient, which was supposed to be also empowered enough to be part of the decision making, or at least be aware where he's standing, this is what he gets in the end. Now, patient questionnaire, when we gave them, right there when they were moving out from, let's say, the ICU or from the hospital, about whatever they were facing, they say that complete information, was it provided to you? It is 60% of them felt. Relevant clinical findings, 45%, they were not aware of what was going on and what was there with them. And informed about the diagnosis was around 62%. But what comes here is verification of previous medication and something more to it that was, which we see in front of us, is information on follow-up to the patient and information about the medication, how they're supposed to be taking. Patient, around 60 to 70% felt. One thing which was good, they were told about the restrictions and also about what is good for them, what is recommended for them, what they should be taking, around 80%. But is 80% still enough at the point where we're supposed to be delivering 100%? We are far away where we are supposed to be. Now what happens is the receiver feels when their communication is going on, why it is happening, and at the sender level. The sender says that too many delays are happening. And the receiver did not call back. Receiver too busy to take report. Well, the receiver says no handoffs occurred, information is incomplete, no opportunity to discuss handoffs with the sender. So this is at both phases, each one of them feels. If we analyze the communication process, at least at the post-op failures which was happening, what comes as a source which was sending the information was post-op handovers was incomplete, or too much of information was provided, or poor illegible handwriting, which was the cause which the receiver was not able to decipher. And at the same time, the debriefing was not happening after the operation, and operation notes per se were getting delayed with the case when it was reaching the ward. At the receiver end, nurse was multitasking when she was receiving the case, and also not receiving complete information. At the daily ward rounds, the similar episodes happen. Information not available to the nurse in the morning rounds when the rounds is happening about the investigation, about yesterday's whatever happened. Morning, the investigation was supposed to be there. She was not happening when the rounds were taking place. Notes, observation, fluid charts were missing. And similarly onto the transmission, poor communication within and across the team, the cross-functional teams, not just one team which is coming. If in the morning one clinical team and the afternoon the second clinical team is visiting based on the diagnosis. And after that, on the receiver end, the care pathways which were not followed. Well, this what came up, and there lies the challenge. That is the discrepancy in the verbal and the written communication. Unwritten protocols, which we are supposed to adhere to because the clinician or somebody superior in the chain has subjected it down. Medication reconciliation, poor patient awareness, and case sheets does not mention, and what comes in front, the impact which comes in, wrong diagnosis, delayed diagnosis, which comes here, inappropriate treatment, medication errors, increased cost and length of stay, and patient complaints. What comes back as recommendation is tools to improve. We should have bedside handovers as far as possible, written orders and checklist. If we are at least having verbal communication, there's a double loop, that is repeat back system in telecommunication, which should happen. SPAR is a technique which we should follow, and speak up campaign where the patient is involved. Now, what I'm trying to focus here is the checklist which has been made over here. When the patient comes to the hospital, he's admitted to the ward, whatever the nurse is supposed to give, starting from the inpatient guidelines, the patient falls, whatever is supposed to be there, she's just checking it on so that she doesn't miss upon. And on the same time, we have devised this where the nursing staff specimen signature is taken on a case sheet, the medical officer's signature is taken. After that, when the diet instructions are given, and whenever the medication is prescribed, the doctor is signing. Subsequently, when the nurse is giving it, the nurse is itself also signing. And similarly, more such formats have been made. Now, SBAR is something where we are understanding the situation. We want to know what is the background, what has happened, why it is happening, and assessment has been made. Subsequently, the recommendation. Now, this is adhered to and it followed up by the next team, so they are aware what the previous people had also felt about the same case. And speak up campaign is where the patient himself is also empowered, is taken up and is asked to speak, to pay attention and educate upon, and so many other things which are highlighted over here. We started with something which is called as an as a tag which is given at the time, let's say for avoiding patient falls. It's a yellow color tag which is given. Geriatric patients, pregnancy, so that they wear and they go across the hospital, everybody is aware they should not fall. And in case they fall, they'll be having more repercussions as compared to others. So people are more careful while the investigations are going on with them. HIS is a very important tool. It reduces the errors which happen, at least the communication between the two interfaces taking place. Sign out when the patient is moving. These are the mnemonic which stands in front of it, the level of sickness which is there, and the alternating data, that is the name about the patient, the hospital course, whatever is there, and new events of the day, whichever is developing, is documented over here. Now, this is important because the team should know what is going on, and the next team which comes up is aware whatever was in the previous day and the present day which was going. I'm just finishing. Give me 30 seconds. Take-home messages. The only and only way we can improve upon is teamwork. We all go in teams, we go in together, take rounds, but somewhere we are still skill-based, which we have as individuals. We may be super specialists in GI surgery, or the anesthetist may be critical care. But where lies the interface of interaction where we come up as a team and we have at least interaction more and more, which is documented, protocols and SOPs, at least of the handoffs which are happening. We need to identify in our setups wherever we are working, what are the critical handoffs which are there. At least based on that, make checklist and protocols at that point. Simplification of tasks and procedure. Simple technique of breaking down an individual's responsibilities and just documenting in front of him, my job. An SOP which states that what is he supposed to do when he receives a patient, 1, 2, 3, 4, 5, 6, hanging in front of him. So it is simplifying his job. He's not into multiple different areas where he's supposed to be working. And subsequently, we have the questionnaires, or sometimes formal and informal, observation and audits of communication. We take it in our organization that communication is going on. It's a thought which we don't think much about. When we go back, we understand it's supposed to happen. It's a taken for granted thing. But the effectiveness...
Can you please wrap up, please?
Sir, finishing. These are the references from the study has come. So I finish here, but I leave a message across that please focus. This is the theme, this is the key area, and this is the driving force where the patient safety can take a new turn, and we need to focus more and more into it. Thank you very much.